CEO and founder of Light65, and welcome to season 4 of The New Normal. On today's episode, we will be discussing ways in which we can address cultural diversity and health equity in healthcare. Before I introduce our panelists, I want to take a minute to thank you for joining us today, as well as thank our panelists for sharing their time with us this afternoon. As for the structure of the webinar, attendees will be on mute and will have reserved time at the end for questions. Please place your questions within the question box of the chat. We can review the recordings of today's webinar at www.newnormal.buzz. Now to introduce our distinguished panelists. Dr. Stephen Shaya, MD, Managing Director of Akkad Holdings. Since 2004, Dr. Shaya has been the Executive Servant Leader at J&B Medical, a global healthcare company. J&B is a privately held, women-owned enterprise operating as a global healthcare consortium based in Wixom, Michigan. Founded in 1996, Stephen worked closely with his father to start 17 different business enterprises that now have customers worldwide. Their companies have brought many new ideas and solutions forward to improve care delivery with strides to improve patient access and quality. His role oversees all strategy, innovation, and growth. Most recently, his family office, Akkad Holdings, is providing the catalyst capital to support a new innovative to advance global health innovation in collaboration with the Cura Foundation and the Vatican. Dr. Shaya attended Wayne State University Medical School and subsequently trained in the family practice at North Oak Medical Center, followed by a fellowship at WSU for occupational and environmental health. Dr. Shaya's efforts have received many recognitions, including the 2015 Global Distinguished Healthcare Award from the Center of Economic and Leadership Development, a United States Congressional Commendation in 2016. He received the Global Medical Innovation and Leadership Award from the United Nations, and he was named the American Diabetes Father of the Year in 2018. Father of the Year. In 2018, Dr. Shaya was invited to speak at the Vatican on how leveraging technology could extend care globally. He currently sits on many boards, including the chairman of the American Diabetes Association in Michigan, Citizens RX, Endeavor, Detroit, Henry Ford Hospital, and Velatura. Welcome, Dr. Shaya.
Thank you for having me.
It's great to have you here. Next is Andre Hughes, founder of Powered by Action. Andre spent his corporate career developing global strategic partnerships and applying technology innovation to power results. A member of the founding partner group at Accenture from 1988 to 2011, Andre helped transform the telecommunications market from voice to data. Now he is using those same skills to propel Powered by Action, PBA, an innovative and affordable platform that can accelerate nonprofit scalability. PBA enables universal access to proven nonprofit programming and help, increases engagement, and leverages rewards to incentive desired behaviors, and that exponential rise social impact. Andre is an angel investor of tech companies and has a large breadth of experience as a board member for various corporate and philanthropic organizations and foundations. Andre's nonprofit board experience includes corporate philanthropy and citizenship through the Accenture Foundation, the Peggy Notebart Nature Museum, the Purdue Krannert School of Management's Business Opportunity Program, the Thurgood Marshall College Fund, the Chicago Urban League, Leadership, Boy Scouts of America, and the Presidential Council for Economic Growth and Development in Haiti. Welcome, Andre.
Good to be here.
Right. And Dr. James Weinstein is a SVP Health Equity and Innovation for Microsoft. Dr. Weinstein is the Senior Vice President, Microsoft Healthcare, where he leads strategy, innovation, and health equity. In 2011, Dr. Weinstein was appointed CEO of Dartmouth Health System, where he brought together a regional hospital to affect the value-based population health strategy. Immediate prior to becoming CEO in 2011, Dr. Weinstein served as president of Dartmouth-Hitchcock Clinic and was director of the Dartmouth Institute for Health Policy and Clinical Practice, TDI, home for Dartmouth Atlas Health Care. In 2015, he was appointed by President Obama to the Special Medical Advisory Group for the Veterans Administration, where he served 3 secretaries. From 2016 to 18, he chaired the first National Academy of Medicine, NAM, Committee on Community-Based Solutions to Promote Health Equity in the U.S., which published the 2017 report, Communities in Action, Pathways to Health Equity. He currently serves on the board of trustees of the Max Planck Florida Institute of Neuroscience, the Charles Drew University Medical School, the Intermountain Health System, and the Advanced Regenerative Medicine Institute, a program for the DoD and Centene. He has published more than 325 peer review articles and published the book Unraveled, Prescriptions to Repair a Broken Healthcare System in 2016. Welcome, Dr. Weinstein.
Just think of Albert Einstein. It's Einstein. Weinstein.
Thank you. Weinstein. Sorry about that. Right. My bad. I'm really sorry about that. But okay. one of the first things, let's go to you, Albert Einstein, Dr. Weinstein. And tell me a little bit about your role that you're doing at Microsoft.
Yeah, it's really interesting, Ken, because I think with my colleagues here and the title of your business, Life 365, the new normal, I think Microsoft's actually right in the middle of the new normal. And as Stephen experienced this past weekend, we introduced a product called Prometheus, which for the audience, they could have access through the new Bing. What this is the open AI efforts that have been started and Microsoft partnered with a large investment back in 2016, where we're using what people think of artificial intelligence, neural networks, and machine learning to actually change most of the things we currently do. And Stephen could speak to that, having experienced it. But I think given this new normal and this conversation, I'm most excited about these technologies potentially being equity tools that take most of the 2,100 counties in this country, which I've studied through the Dartmouth Atlas and all the zip codes, and actually start to actually change some things. Through our committee, through National Academy of Sciences, as you mentioned, bringing that work to Microsoft and technology to have an impact to affect change is what I'm most excited about. I think all of us on this call and those listening have been involved in lots of discussions around health equity. I've been quite disappointed in the actual outcomes of those discussions. I don't think we've actually moved the needle very much from a health outcome standpoint. And I think the models we're using, which I hope we'll get into, I think need to change. So despite lots of resources and lots of money, I'm not sure we're making the kind of commitments and the changes necessary over long periods of time to sustain and change the structural inequities in the United States.
All right, that makes a lot of sense. Let me go over to, I want to hear from Andre next and kind of go through and tell us a little bit about, what you're doing in health equity as well and cultural diversity as well, working in healthcare. Tell us a little bit about, your company.
Well, the first thing that I would say, I would just agree that our current systems really favor certain populations. And when you look at vulnerable populations, and particularly people of color, you find that those same systems have not created the results that any of us would have wanted. Certainly when you look at diabetes, kidney disease and maternal mortality. Black people suffer at 2 times, 3 times, and 4 times the rates, respectively, for each of those 3 domains. And so none of us are proud about the results that the current providers that participate in this industry have created. And so I would agree wholeheartedly that the way that we do things have to be done differently, because it's insanity to think that the current stakeholders are going to change or their approaches are going to change enough to change the results that we've lived with now for decades. The second thing that I would say is that I think we have a very interesting opportunity to listen a little bit more and to do more effectively what many of those individuals that we all seek to help would suggest we do to change what we see. And so one of the things that we're working on is empowering communities with the tools that they need to change their own circumstance. And I think this has been not necessarily the approach that we focused on in the past. And so the technology that we develop here in Chicago and Qingdao, China, and in Bratislava, where our software teams are, focuses on leveraging the power and the might and the influence of trusted parties, pastors, heads of nonprofits. These are the people that many of these vulnerable populations believe in and trust. And so I think this has been overlooked, or they haven't been engaged properly to leverage the influence that they have. I think the second thing we focus on is how do we give these trusted advocates the power to onboard the people that they work with and have influence with, and how do we give them the tools so that they can engage their members along the dimensions of change that everyone wants. And so on our platform, we deliver all of the social services that nonprofits and churches provide, and we invite for-profit allies that deliver the for-profit services to participate as long as they are good allies. And when we say good allies, we mean that they truly want to create better outcomes with these individuals versus only want to secure profits in excess of whatever their goals and objectives are. And so I think this model is a model that I am certain will work. The evidence that we're starting to see points us in a direction where the engaged populations on our platform have not heretofore ever been engaged quite the same way. And so you have large organizations like insurers and pharmaceutical companies in particular seeking to team with us for these purposes.
Yeah, Andre, I want to go back to you and do a follow-up. I want to get to Dr. Shaya here in a second. But some examples, right, that you're seeing of best practices that are starting to be put in place, right, from that, and where we can do better, right, from that. So Dr. Shaya, tell me about, about your work with, underserved communities, health equity, the Vatican, philanthropic, side of it, just what is your mission that you're going after? And I know you're passionate about.
Well, thank you, Kent. And thank you, Andre and Dr. Weinstein for having me today. So just a little background, J&B Medical is a family-owned, privately held enterprise. My mother owns 100% of J&B today, so we say she's boss at home and at work, and she reminds us quite often of that. But we have various lines of business, which include medical distribution, providing everything that goes in a hospital, pharmacy, physician's office, to some specialty distribution businesses. Our claim to fame is we're one of the largest third-party billers of consumable medical products to the homes in the United States. We reach over 260 million covered lives via insurance contracts. We have a telemedicine, telehealth company. We're doing virtual visits, literally in places around the world. And we also now have a mail order pharmacy license in 48 states. From the very beginning, we've been a very mission-driven enterprise. It really started with my grandmother, who was a midwife. She delivered thousands of babies in a very small city in Iraq. When she had her 12th child, when the 12th child was in utero, her husband died, and she raised all these children on her own. And her whole life was about servant leadership. It was about giving back, and it's something that really left a very deep imprint on myself and my siblings and my mother. So our focus at J&B has always been on the underserved and elderly, providing accessibility and affordability to products and services. We've been able, through numerous programs, to save our various customers, whether it's state government, federal government, payers, hundreds of millions of dollars, while helping improve clinical outcomes and quality of care, with a keen focus for us being the underserved. Our thinking has really evolved. We went from kind of being disruptors and providing products and services to patients in the home and building a better mousetrap, to, much like Andre, looking more holistically at the challenges the underserved have. So, real life example, a patient that's on insulin, you may get them their diabetic test strips, you may get them their continuous glucose monitor, you may get them their supplies, you may get them their insulin. But if they don't have a refrigerator, we have challenges. And there are a lot of these very real life challenges that we had to deal with. So we've been working very actively on the social determinants of health, or we like to call healthy opportunities, to help screen patients and try to find solutions that could help best match their needs. And so we have a variety of different programs that we've started along those lines. And I think when you talk about health equity, you really have to start at the very basic level. A huge portion of medical care are non-medical factors. And I think that as we look at particularly the underserved population, many folks take certain things for granted: transportation, financial capabilities, et cetera. And so we're really trying to help bring solutions that help fill in some of these gaps in the whole continuum of care, both medical and non-medical.
That's awesome. One thing, James, that I put together is I did put on the part of the title talking about, health equity, but also cultural diversity. And they're not necessarily tied together. They can be, right, from that standpoint, from it. But, from your perspective, just give me an overarching definition of what you think that is health equity in the United States, and where you've seen best practices maybe in other countries throughout the world.
Yeah. Well, it's quite disparate, even within our own country, as we know what that means. I've often written that geography is destiny, and based on one zip code where they're born, kind of determines their lot in life. And we published this many times from the Dartmouth Atlas work, and then through the national academies. I want to suggest that diversity is often structurally confined. And I think Andre is pointing to this. Our committee recommended, and it's not just Black America, it's India America, it's Hispanic America, it's white American, many Appalachian communities. And What we've done is we've created an infrastructure, both in the banking world, the large industry world, where we've put populations at risk. I mean, you can look at the recent accident in Pennsylvania with the trains, the electrical power grids. We studied 4-year intervals from 2016 to 2020, about 20 or 3,100 counties in the United States. And what we see is things are actually getting worse in except a few areas. And when I mean worse, the health outcomes are worse, the rates of diabetes are worse, the low birth weight babies, the mental issues. And yet we continue to spend money on a structure that doesn't address the issues that Andre and Stephen are talking about. You know, healthcare is a $4 trillion industry, but it really doesn't address the issues of health. And so it's kind of interesting to me how much we spend on an infrastructure of healthcare, which I was a surgeon, I practiced in, I was the CEO of a great system. But the problems live outside the healthcare system. By the time they get to the healthcare system, it's often really pretty late. And just the thing Stephen had talked about, having refrigeration and power and access to medication, compliance with treatment, good food, nutrition sources, a place to live. We take all these things for granted, us on this phone call. And to Andre's point, I worked with Reverend Bobby Baker in Memphis on a project, which was run through the church for getting vaccinations done during COVID. And Bobby's team had no infrastructure, had no payment system, but the people in the community trusted the church as a reliable resource, or the barbershop. You're all familiar with these things, but the point is, we as a society do not support that infrastructure as a business to be sustained to actually create change. We continue to increase Medicare funding and all these issues for the current system, which has failed us. And I understand what the importance of, you know, transplants for kidneys. I'm working on a Department of Defense grant to actually make artificial kidneys from one's own stem cells. We're not that far away from that. But that's end stage disease that's almost too late.
Too late.
We need to be way upstream and have very different community-based models, as both Stephen and Andre are pointing to. And it's not just the United States, it's globally. But we continue to fund the infrastructure that we're used to. And I always say, if we always do what we've always done, we'll always get what we've always gotten. And every system's designed to get the results it gets. And we're going to continue these results unless we change the system upon which we're trying to actually affect better outcomes.
Yeah, I think that's one of the challenges that I always face in healthcare, is that I consider myself a healthcare innovator, but I'm always innovating for what I think healthcare needs and should need, right, to be able to get to people from that. But healthcare isn't necessarily adopting, right, those new and innovative ways to try to reach people or connect people now.
They weren't built to do that. They were built to take care of difficult problems in a hospital, to fill hospital beds, supply-induced demand. You know, so if you build beds, you got to fill them. That's their financial model. But it's way upstream that we need to be in these communities, you know, down in first and second grade, where we start to change what's going to happen over decades, not once they're in the hospital. It's way too late. Right. And I don't see the discussion at any level that's looking at the structural problems we've created. More people die in the hospital just based on how many hospital beds than they do where they live for other reasons. So hospitals can be dangerous too. The IOM report on accidents in hospital, 44,000 a year. So let's not bash hospitals. I ran one, but let's figure out how to get resources into the communities in a sustained way in a business model that we can all support, with a vision of changing the many variables that actually affect lifespan and good outcomes.
But Andre, don't you think that, no, go ahead, Andre.
I would just add to what James is saying by saying that many receive the most of the worst and the least of the best. And that's because up to 55% of the things that drive care or outcomes have nothing to do with the medical and healthcare infrastructure. Up to 55% has nothing to do with healthcare, healthcare products, or healthcare services. 55% have to do with, as James pointed out, zip code, socioeconomic status, access, and people's beliefs and biases. And so the systems that exist that support the $4 trillion business, the business and corporate infrastructures that exist, those things don't support what James and I are talking about. Those things aren't built to support what James and I are talking about. Those things that are corporately built are structured for the business of reacting to bad diagnosis. And so what James and I are talking about is, how can we empower communities to empower themselves? Many of those communities are very engaged in certain things that they trust and value. For example, as James pointed out, they're very involved in their church. And so what we're doing is we've built new platforms with our own financial resources that are outside of the normal, where these organizations that are doing good can onboard themselves and onboard their constituents and use the platform for their purpose. If it is a church, as we've talked about previously, that church on our platform can stream its own Sunday church services. It can host interactive Bible studies on our platform. It can deliver mentoring programs and tutoring programs. It can do all of these things that it does as a part of its mission as a church to engage its constituents. What we've done different is we've put this technology in their hands and allowed them to brand it as their own, which drives even more engagement. And then we've integrated telemedicine, care coordination, remote patient monitoring services onto the church's platform so that those members that use the app for church services and Bible study and seeing their daily inspiration, they also use it to connect with the physician. They also use it to connect with the psychiatrist. They also use it to see their care plan. They also use it to exercise and be reminded of what they should be doing today, what medicines they should take, all to drive the one, to resolve the major issue that we have, and that is engagement. If you can engage this population that has 2x the diabetes, 3x the kidney disease, 4x the maternal mortality health, and 5x the imprisonment, if you can engage them around the things that they value and then infuse these things that we're talking about here today, the change is evident. And so, but this is not the business of the companies that support the systems that exist today.
I think
this is a completely different business.
Yeah. I think that's one of the things that you just enlightened me in 17 years in digital health. I think you just enlightened me of the misalignment, right, of care and social needs and everything else. But I think the light bulb just finally went off, because I'm trying to shove it down the throat of providers and health systems, saying that's your responsibility going forward. You're going to be doing community-based care, for this. I'm like, we're not in the business to do that, right? And so adoption is like really super poor, because they're like, that's not our business. Our business is to treat sick people, right? From that, sorry, not to make them better, right?
Ken, I think you're onto something, because for some of the insurers that we're talking to and some of the pharmaceutical companies that we're talking to, the light bulb went off for them also. Mm. And what they're suggesting is the same thing that you hear James talking about, that I'm supporting. And that is, these corporations, and I think Stephen, I think he has a similar business that will benefit from this. I think all of his businesses will benefit from what I'm suggesting, is that if we can put the power in the hands of these trusted advocates, I think these businesses that are calling us are saying, can we launch a channel on your platform so that people can join our clinical trials? Mm-hmm. Can we launch a channel where the people we insure can come onto the platform and be a part of the platform and get access to this suite of services that they've not heretofore been able to access in the same way?
Can I just pick up on Andre and Stephen's comment? Because what I see now in the technology world, and both Stephen and Andre's work can contribute to this, because the AI models are also built on structural problems. They don't incorporate these populations. And so Stephen's work in diabetes is critical. We should figure out how Stephen, Andre, myself, and others can actually improve the engagement so that we can actually build better models upstream to help populations at risk, whereas today's models, I think, are biased in many ways. And this future, this, as you call it, the new normal, can't be new unless we start to incorporate these things.
Yeah, well, and you've got to start, sorry, Stephen, I'm gonna let you come in just a second here. You've got to start farther upstream too, because one of the major health systems that we work with, renowned health systems that we work with, has 20 years of electronic health data. And they're like, we can identify that and provide it into your models and your AI and machine learning. But the problem it's missing is cultural diversity, because they're not inclusive of that in welcoming cultural diversity into their patient base, right, from that. So their models are always going to be skewed poorly, right, in the wrong direction, because their business model doesn't incorporate it.
Yeah, let's not criticize poorly, but let's say that they're not inclusive, because the models might be good for the people they serve, but have no relevance for the people they don't.
Right. Well, they're coming to us saying, how can we actually make it more culturally diverse? From that, you got to go upstream.
I'm just giving you a hard time, Ken. That's all.
No, that's fine. That's fine. I understand that.
Yeah.
Kurt,
but I think
call me Kurt.
Stephen's business with the supply chain and Andre's work in those communities, we have opportunities. This goes to Andre's comments. We're not even taking advantage of what's possible at the right level to provide things that actually make a difference in a much larger scale. We're just not. Yeah.
Stephen, chime in.
I was just going to add two things to what Andre said. You know, my late father always used to say, total health. the health of the patient, the health of the employee, the health of the community. So when I met Andre, there was immediate alignment because you need all of that if we're going to really move the needle into what James is talking about and how intervening earlier upstream. One of the biggest challenges in all these models is, we always say innovation is integration. And the only way we can actually move the needle is to kind of integrate it in the delivery of care, and be able to tie in the incentives with all these services that are being offered. So we deal with many of the insurance companies in the United States and many around the world. And, it's a constant education process to what James and Andre are talking about looking at this more holistically. I mean, look, at the end of the day, the U.S. healthcare system is the fourth largest economy in the world today, and it's going to be the third largest in the next couple of years. Think of it in those terms. I mean, it's staggering and it's not sustainable. So I think what both James and Andre are talking about from different perspectives, absolutely critical, not just for our communities, not just for the underserved, not just for the elderly, but our entire country, and I think it's so important. We have to really look at this, whole healthcare equities in a very holistic way.
Stephen,
go ahead, Andre.
Stephen, the thing that I would just add, and thank you for saying that, is that we must appreciate this notion of cultural diversity.
Yeah.
Because I think that I believe that all the resources necessary to lift up a fallen people exist. I remember when God made that clear to me. I think what we have to do is to make access to those resources possible. And we have to tailor those resources to the populations. This is what I mean. I think organizations like the Center for Disease Control have huge investments in diabetes prevention programs. I think the American Diabetes Foundation, where Stephen is a member and chairman, I think have huge programs. But if those programs are teaching me how to make Wiener Schnitzel, that's not going to do much for Hispanic or a Black population. So what we have to do is we have to take these programs that really address a broader population, a more vanilla population, if you will, and we have to provide some flavor to it. And so on our platform, when we are delivering the diabetes prevention program, we're working through organizations like the Black Women's Health Imperative, where we work with them to tailor the diabetes prevention program to Black women. So in that program, all you see is Black women. The language that's used is language that Black women use. All of the speakers, the life coaches, the exercise coaches, the cooks, all of them, the food. It's all food related to this Black or Hispanic family. And you're teaching them how to modify what they do normally. So you first got to know what they do. You have to first know what they do. So you got to go ask the right people. And then you have to work with the people with the knowledge to modify what they're doing so that their families can be healthier. And so when you're mentioning, Kent and James, cultural diversity, on our platform, we're delivering culturally specific programs for diabetes, for kidney disease, for heart disease, culturally specific programs. Right. And so this does what James says. It makes those programs and services relevant. Same thing when it comes to telehealth on our platform, connecting many of those same people to physicians and psychiatrists that look like them, that know their story, that can benefit from looking like me so that the patient is comfortable sharing information that historically they don't share with just someone that doesn't look like them. And so these elements, including identifying these trusted advocates, barbershops, churches, hair salons, this is where the conversation flows freely. This is where the opportunity is. And if we want to change communities, we got to empower these groups with technology that looks very different than the technology that we see most companies developing. And that's why we've developed it in alignment to their needs.
It's not just technology, right? I mean, it's knowing where people come from to know where they can go, and relatability and engage them, right, from that as well. Because
well, you've got the tech kit, and you got content, and you've got data, and data is crucial.
And content's crucial, right? To be in the content
is crucial. So it's not just tech. It's not just tech. And you know, for some people, it's even a person that will do the outreach, hold them by the hand, and guide them long enough until their feet are sure and they're comfortable walking on their own. We can't dismiss the power of human connection and human touch. And so all of these elements we know to be true, and we're smart enough to make them happen for these that need it most.
And Andre, can I add one thing? I want to just dovetail on something Andre said. Many people think the future of healthcare is tech, TECH. I would submit that the future of healthcare is tech, TECC, technology-enabled care coordination. And that's a lot of what Andre is talking about. How do you kind of coordinate all the various key stakeholders? So I really believe that's the future of healthcare, technology-enabled care coordination. Tech plays a big role in that, but it's not the answer.
Yeah. The one thing I really liked through my last company, they really were working with congregations. And I loved how congregations, when you gave them the tools and just backed out of their way, right, to be able to do their thing, how they empowered each other and came together, right, from that as well. You know, you're not shoving down procedures down their throat, technology down their throat, saying you have to do things a certain way. You're actually giving them the tools and letting them support themselves. There's nothing better than people supporting themselves within the community and within the church, right, from that under their either their responsibility or their servitude to God, right, as well, in community and fellowship.
This is how we solve the four major issues that are deep-seated issues and that are represented by: we don't trust them, we can't access it, we don't know, and it's too hard. This is how we solve those four problems. That, as James was suggesting, and I was talking about earlier, are the four issues that limit engagement. If we can't solve these four issues, we can't accelerate engagement. If we can't accelerate engagement, we can't expect different outcomes. And so we've got to find ways to engage the unengaged, or they will pay for it and others will pay for it. And so we don't want either of those things to happen, because we know what that's like. And so engaging them so that they can help us engage others is the solution.
Right. And to your point on this, healthcare is just one little aspect of that.
About 20%.
Right.
About 20%.
Behavioral health, emotional health, economic health, all of it kind of gets wound together. Guys, we got to wrap up, this, but I want to go back to each one of you, right? Because I promised we'd do about 45 minutes today, and this is just a great conversation to have with some great thought leaders. James, from your perspective, what do you see as working out there as a good model to start moving forward with that we should start, looking deeper at?
I think the socioeconomic issues are underrepresented in the solution set. So if you look at communities that are in the lowest quintile of socioeconomics, they do the worst in almost everything. And that's a structural problem. What works the best is, I go back to Andre's thoughts, is really what that community thinks works the best, not what I think is the best. And we have, at Microsoft, we have 198,000 healthcare partners around the world. So we're a big company. And we impact a lot of people behind the scenes because they use our technology. We're not a front-facing first party besides the technology, the TECH technology. But I would like to suggest that our leadership under Satya Nadella is very committed to the issues we're speaking to around the world. And we walk the walk. We're not in the news about, trying to change healthcare or be healthcare. That's not our business. I've lived in healthcare, and I don't think most technology people understand healthcare. I think Andre's work, which I'm not familiar with his platform, and I hope to learn, or Stephen's work is probably some of the most important work that we, Microsoft, are not aware of. And how could we help spread and scale that work in the communities? Well, we don't have these partnerships. The business roundtable is big companies, but they aren't addressing these issues. There's a lot of talk, and it doesn't change much. And so I'm looking for partners who actually want to change things in a measurable way that we can quantitate. And as we know what's in a cereal box by looking at the side, I'd like to know what we've done to affect the community by that cereal label that they think is important, not what I think is important. And so that's how I'd like to see us go forward. So I'm just so thankful, Ken, just to meet Andre and Stephen and yourself. So thank you for the opportunity.
Yeah, we're glad to have you here too as well. I'm glad we could bring everybody together. Stephen, what about yourself? What are you seeing? You mentioned that you were just part of an innovation forum. You've done work with the Vatican. From that, what are you seeing from the United States or around the world that you think are best practices that we should be emulating?
Well, to James' point earlier about engaging, key stakeholders, not just the big corporations, and to what Andre is doing today in the communities, I would just submit to everyone that the only thing that's ever created lasting, sustainable change is a bunch of thoughtful, committed people working together. And I think this discussion is, presents some opportunities for collaborations, and there's no one person, there's no one technology, there's no one stakeholder that can move the needle. It takes a village. And Sir Isaac Newton said it best: if I've seen further, it's because I stand on the shoulders of giants. And I think, having this discussion with people like Andre and James, and thinking about what it takes, we all have to come together. I think a big challenge is alignment, a big challenge is values. And I think we saw during COVID that, even if the United States was good and other parts of the world were not, we weren't good, because eventually it would affect us. And I think that is one of the lessons we have to learn from the pandemic, that we have to look at things in a very global way. And we have to look at all aspects of our society, because it takes a village to make a lasting, sustainable change, and it's every aspect, every person matters.
Awesome. And Andre, I'm going to finish up with you. Your thoughts of where you're seeing best practices. Obviously, you talked to us a lot about how we can improve things as well. But, you know, just end with your ending thoughts.
Well, again, I'm humbled to be here with James and Stephen and yourself. The resources from companies like Stephen's company and Microsoft that James represents are crucial to the types of partnerships we're wanting to develop. I think in the end here, and James, you said it, this is about economics. And I would just share this word, this phrase, shared power. I think there has to be a shared power revolution. And I think when I think about sharing power, we're talking about sharing capital. Now, we're not talking about giving people things. But I think when you look in the hands of these vulnerable populations, they are asset rich with disease. Those diseases, when monetized, creates companies worth tens and hundreds of billions of dollars. If you just take kidney disease as one example, each session is $4,000 to $6,000 per dialysis session. Those companies don't come from inside the community. There is no reason why we can't do home dialysis, and we can't do it with companies that deliver it that are housed in those communities.
Yeah.
There is no reason why that can't. Their disease can be monetized, and those monies can fund the incentives, the rewards, and the investments necessary in those communities. And our intention is to invest the hundreds of millions of dollars on our own to fund it, to build out the platform that we've built, to integrate these services, and to put these types of capabilities in the hands of the communities so that they can serve themselves better than anybody else. And that shared power approach will change the outcomes for them and the broader community as a whole. So I look forward to working with Stephen. He and I had met prior to this. James, I've heard a tremendous amount about you. I look forward to hopefully some follow-up discussions with you about how we can work together in Kent. And I just want to thank you again, Kent, for pulling this all together.
No, it's my pleasure to have you guys all here as well. So I'm glad we could do this. But let me reclaim your time, right, from this. You've done a great job in educating our group today, and I want to thank everybody for attending. Thank you, Dr. Shaya. Thank you, Andre and Dr. Weinstein from this for your participation and your great insights. We'll post the recording on newnormal.buzz. You can find the details on upcoming episodes there as well. We should have this episode out later this evening or maybe early tomorrow. But thank you, everybody, for participating. I really learned a lot, and it kind of opened my eyes of like really aligning what I'm personally doing in this industry, probably a little bit differently, right, than what I thought about earlier today. So have a wonderful evening, and thanks, guys, for participating.
Thank you, Andre. Thank you, James. Thank you, Kent.
Thanks, guys.
Thanks, everybody.
Take care.
Bye.